You are live now, ma'am.
Good evening, everyone. Welcome to DOS Super Tuesdays, an initiative by Delhi Ophthalmological Society. This is our third episode of corneal surgery learning course, and the topic for today's webinar is transition from penetrating keratoplasty to Descemet's membrane endothelial keratoplasty. I'm pleased to introduce and welcome our speaker for today, Dr. Omar Rashid. Dr. Omar Rashid is currently working as Medical Director, Consultant Cornea Cataract and Refractive Surgery at Perfect Vision Super Specialty Eye Hospital, Srinagar. He has done his post graduation from GMC Srinagar and did his fellowship in cornea and microsurgery from Arvind Eye Hospital. He has worked as senior residency from Max Super Specialty Hospital, New Delhi, and he has worked as ex-consultant at Arvind Eye Hospital and Dr. Manzoor Eye Care Center, Srinagar. He has also worked as former lecturer in ophthalmology at GMC Srinagar, and he has ample teaching experience in teaching undergraduates, training postgraduates, as well as fellows. He is an active member of various societies. I welcome Dr. Omar to our virtual stage. So you can start sharing your presentation.
I hope I'm audible to all.
Yes, sir, you're audible.
Okay. So, a very good evening to all of you. First of all, I would like to thank Delhi Ophthalmological Society for inviting me for this talk today. And I would also like to thank our sponsors, that is Joja Surgicals. So, let us start our presentation. So, my topic for today would be transitioning from penetrating keratoplasty to DMEC. So penetrating keratoplasty has been a gold standard in all keratoplasties since it was introduced in 1900 century by Zerm. It still has relevance in modern day keratoplasty even after more than a century. So even when we are trained as a fellows in any fellowship course, PK is the first uh, surgery, corneal surgery, first keratoplasty that we are being taught. So it's like a stepping stone for everyone. So why transition from PK to lamellar surgeries? So let us talk about some of the complications of penetrating keratoplasty. So during surgery, we can have iris prolapse, lens extrusion due to high positive pressure because it's an open sky procedure. Then we can have vitreous loss. You can have the dreaded expulsive choroidal hemorrhage. Then post-operatively, you will see sometimes epithelial defects that won't heal for no reason. Sometimes you'll have wound leak. Sometimes you have secondary glaucoma due to intrinsic causes or maybe steroid-induced glaucoma and high astigmatism, even if the suturing is good, because astigmatism doesn't only depend on the suturing, it might be there because of the healing between the host and donor junction. Then you may have episodes of graft rejection, which can lead to graft failure. So, even if you don't have all these complications, still there is a long recovery time till the patient gets a good vision, good amount of vision. So, in order to avoid all these complications, we move on to these modern endothelial keratoplasties, which is DMEC, that is Descemet's membrane endothelial keratoplasty. It was introduced by Mells in 2006. Actually, he introduced DSEC in 2004, and then after 2 years, he went on to a better form of surgery, which he said is the only true anatomic exchange of the diseased endothelium and Descemet's membrane. The thickness of the tissue transplanted here is around 6 to 10 microns. So if we talk about the major forms of endothelial keratoplasties, let us talk about DSEC or DSAEK first. Here in the diseased endothelium and the Descemet's membrane is replaced by endothelial cells, Descemet's membrane, and a portion of the stroma, which might range from around 150 to 200 microns. This graft can be harvested using a manual method, or it may be uh, harvested by an automated method, which is by employing a microkeratome. So, in that case, it is known as a DSAEK, that is automated endothelial keratoplasty. Then some people even go for this ultra thin dissect where they again use this microkeratome, but the depth of the blade is different. So the thickness of the tissue is less than 100 micron. Results are quite good. They might be even comparable to DMEC. Then we have the third surgery, which is known as Descemet's membrane endothelial keratoplasty, where only the cells and endothelial cells and the Descemet's membrane is replaced. Here, hardly the thickness of the tissue is around, say, 6 to 10 microns. There is one more form of endothelial keratoplasty which was introduced by Dr. Agarwal and group, which is known as PDEC, pre-Descemet's endothelial keratoplasty, where they just include the Dua's layer along with the endothelial cell and the Descemet's membrane. However, in these cases, we have seen that graft harvesting is a little bit difficult, and only at present, only 7 to 8 grafts can be harvested using this technique. So this is what we have PK versus DMEC. In penetrating keratoplasty, we are actually replacing everything, starting from epithelium, Bowman's layer, stroma, the Descemet's membrane, and the endothelial cells. Whereas in DMEC, if only the Descemet's membrane, I mean the endothelial cells only are defective, only change Descemet's membrane along with the endothelial cells. So what is the advantage of doing a DMEC versus a penetrating keratoplasty? So it is not an open sky procedure, it's a closed chamber procedure. The recovery after the surgery is quite fast. Better optical quality is reported. There is no or minimal hyperopic shift. Smaller wounds can be employed, same as we use in phacoemulsification. And the rejection rates are quite low. Like for DMEC, it has been reported for to be around 0.7%, around 9% for DSEC, and 17% for PK. So among all these surgeries, DMEC has the lowest rejection rates, and the patient can be off steroids in about a year. So if there are so many advantages in doing a DMEC, why everybody is not transitioning? What are the obstacles? What are the hurdles? It is a challenging technique. It is not as easy as it appears on videos. Then there are chances of getting an iatrogenic graft damage, or you can have a graft failure. While harvesting the graft, you might actually lose a lot of cells, which may lead to graft failure. Then there's the question of relatively higher rates of detachments. Even if you like compare it with the DSEC, the detachment rate is quite high with DMEC, and especially it's more when a surgeon is in the earlier stages of his training. And above all, we have the main thing, which is the mental block. So we don't actually want to come out of our comfort zone to change our technique and go to a new technique where we might initially face challenges. We might have complications. We don't want to shift from that comfort zone to a more difficult surgery. So how can we overcome all these obstacles and transition from PK to DMEC? So very important in this section is case selection. So initially, I would suggest that all of us, we should choose uncomplicated corneal decompensations with round regular pupils, and we should have a stable PCL in the bag. Then we should also have an eye on the AC depth. It should not be too shallow. It should not be too deep. We should avoid eyes like who have crowded anterior chambers. We should avoid high myopes. Then we should also have a look on the peripheral scarring. Like if somebody has a very dense arcus, or somebody has very advanced PBK, where it has already started to scar, it's better to avoid those cases in your initial periods. And then you should pre-record horizontal white to white to keep an eye on the graft size, because sometimes you harvest a graft of say 8.5 millimeter and the eye is quite small, so it becomes very difficult to unfold those grafts. So initially you should have an idea about the horizontal white to white so that you can manage your graft size. So before going to the steps of the surgery, let's talk about the graft morphology. Like when we harvest this graft, what is the natural position of this graft which it acquires when we like take it into the anterior chamber, or even if we put it into the this petri dish filled with BSS. So it has been observed that the DM always remains on the inside. It folds on itself, the graft folds on itself. The endothelial cells are always outside, and the elastic DM is always on the inside, which can be seen in this image. So going on to the steps, we can grossly divide it into four steps. One is like donor tissue preparation, one is donor tissue loading, then host preparation, like preparing it for desmatorexis and for graft adhesion. Then fourth one, donor tissue insertion, unfolding, and tamponade. So I would recommend initially everyone should harvest the graft first and only then start draping the patient. It's not a good idea to block the patient first, uh, put in a drape, put in a speculum, and then go to the harvesting part, because you might actually be putting in another 10, 15, 20 minutes for harvesting the graft. And by that time, the patient might become like uncomfortable, or he might start moving, and he might even start losing the block as well. So we come to the donor tissue preparation part. First, you have to give yourself 1 or 2 sessions in the wet lab so that you get a feel about this DM, how it feels to touch, how it actually behaves when you put it into this petri dish. So it's a very good idea actually to get a feel of things in a wet lab, at least 2 to 3 sessions where you learn the peeling and everything. Then it would be again a very good idea to choose older donor grafts. Like the age should be around more than 60. Then phakic eyes counts say around more than 2400, and preferably a non-diabetic patient. Then it is also a very good idea to use pre-stripped tissues to begin with. So right now in India, there are a few eye banks who are supplying these pre-stripped DM scrolls. They are actually stripping it. They are putting a Trifine there for S stamp, and they'll just replace it back and send it to you. So it is a very good idea initially if you use these pre-stripped tissues, so that you don't have to deal with the stress of like damaging the graft while doing the surgery, and then it really discourages you if you lose the graft. So in donor preparation, what we do initially is stripping of DM using two instruments, which is recommended. Then peeling from quadrant to quadrant, like we can shift your instrument position from one quadrant to another. Then it's very, very important to put in a marking, put in a stamp. You can put in S stamp or P stamp, even some people use that F stamp. It's very, very important for you to mark it on the stomal side so that you have an idea when the graft is inside the eye, you get an idea about the orientation of the graft, whether it is in the right position or not. Then it is of utmost important also to stain the graft with Drapen blue for at least 2 minutes. Some authorities even stain it for say 3 minutes to get a good contrast when you're inside the AC. Then we transfer the graft from the Teflon block to the Petri dish filled with BSS. So this is our first video. We're using a three-step tissue here. 3 mm Trefine has already been done. We dry the area with a Vexel sponge and put in this S-stamp. These S-stamp instruments are available in India. These are available with Georgia Surgicals as well. Then we put in just 1 or 2 drops of the stain. And then you can start peeling the graft. Mark the graft size. This is partial depth definition. You should not go full depth because sometimes it might tear the graft. So since this is pre-step, it's very easy to peel it after removing the peripheral strip. We're going from quadrant to quadrant and transferring it into a petri dish. This is another case which demonstrates that sometimes your 3 mm Trefine may not be full thickness. It might be attached to one end. So what we're doing is we're just using a needle to lift it. Dry the area and you can complete the division using cornell scissors. Put in the stamp. It's very important to get the stamp. Partial depth definition. And stain it again. So this is a donor suction Trefine which has recently been developed by Georgia Surgicals. Previously, we have an idea about host suction Trefines. Baron has Trefine which creates a vacuum while we are making those turns, going a partial for a partial depth definition. This one is developed by Georgia for actually harvesting the donor tissue. So it can be used in all corneal surgeries. Like we can use it in PK, we can use it in even dark, you can use it in DMEC. So it has this, I'll show you the marker. It has this syringe attached to it, which creates a suction over this block area where you can place your graft, and it holds the graft into one place. It doesn't allow the graft to slip. So this is the same define. This video has been lent to me by one of my colleagues, one of my friends. The graft is held onto this place on this block by suction. Is done the initial staining. This is by the way, a manual method of doing the peeling yourself. This is not a pre-step tissue. After peeling, say 50% of the graft, you put it back and make a trephination, partial depth trephination. And then put in a 3 mm Trefine for putting in a stamp. So this is another very useful instrument. This is a 100 micron partial depth refine. This can be used in DMEC to create a partial depth definition. So it doesn't go all the way through the graft, and the chances of getting a tear are very less with this refine. So next is the graft loading. So now we have actually harvested this graft. We have shifted it to a petri dish containing this BSS. Now we want to load it into the injector. So there are a lot of injectors that people are employing these days. A simple IL cartridge can also be used. Then there are glass pipettes from Goider. So my preferred technique is to use glass injector, which is again made from Joja Surgicals. It comes in two sizes. So this is a 2.2 and 2.8 mm size. You can see that it has two ends. One is a narrow one, which goes into the AC, and then there is a wider one, which is initially used to suck the graft inside this glass pipette. So the graft is loaded under BSS from wider end using a connector and a 3 ml syringe. And we have to make sure that the graft is in double roll configuration inside the tube before you go for an injection. So even if you have to like take it out of this DMEC glass injector, it is better to get it into the proper orientation before you're ready to like inject it into the AC. So I remember when I did my first case, I was so nervous that I loaded the graft inside this pipette, and I was sure that the graft is upside down, but still, I was so scared to take it out. I went ahead and put it into AC with the wrong configuration. So that should not happen. So now we have this graft inside the petri dish. We put a little bit of spurts of BSS to try to get it into a rolled configuration. And then we immerse this wider end into the BSS without taking any air. See here, I just lifted it a little bit, and when I suck, air goes inside. So this is not a preferable technique. Even if you're creating a suction, it should always be done under BSS. So that we don't have any air inside. So we remove the connector now and attach the 3 ml syringe to the wider end. So now our assembly is ready for loading inside the AC, but we'll just check once when we are going into the narrow part whether it's in the correct configuration or not. Should be in the double score position. So now a graft is ready to be injected. So we have to uh, prepare the host. So we first step is removing the epithelium. It is must for proper visualization because of this diseased epithelium, you might not be able to see the anterior chamber properly. So even if the visualization is good, it's a very good idea to remove this epithelium because you want to remove this epithelium, remove all the tags, have a smooth margin so that you have a good re-epithelialization after the surgery. So see here, the visualization was quite poor. So now we are removing the epithelium. We should go all the way to the periphery, remove all the tags so that a new epithelial layer grows in quite nicely. So after we have removed the epithelium, then comes the wound construction part. So in this diagram, we can see the blue part is the graft area where we are going to inject a graft and say if a graft here is like 8 millimeter size, you have to make your descemetorrhexis larger than this, preferably say 0.5 or even 1 larger than your proposed graft site. So when you place your incisions, make sure that these 1, 2, 3, 4, these yellow color, they are all incisions. Some make one main wound, then one or two paracentesis. Some people even prefer to use three paracentesis. My preferred technique is to make a main wound and two paracentesis, but all of these wounds should be outside your descemetorrhexis so that there is no overlap with of these wounds. When you are putting in your graft, there should not be overlapping with your incisions or interfering with your incisions. So in the host preparation part, next comes the descemetorrhexis. So before performing a
Any
descemetorrhexis,
isn't
it's quite important to stain it with a
it?
trypanidine first. trypan blue first. Some authorities even do it with the dilated pupil. If the red glow is quite good, that is also fine. But I would recommend all of you to like stain it with trypan blue to start off with. Then some people do this desmodorexis under air. Uh, if you are comfortable with that, the problem with the air is like when you start to enter the AC, sometimes you have to refill it again and again. You can use a vitrectomy machine with a continuous airflow to do the desmodorexis. But my preferred technique is to use a cohesive viscoelastic like sodium hyaluronate 14%. That gives you a quite stable anterior chamber, so you can perform your desmodorexis quite comfortably with that. So it starts with scoring the edges, then stripping the DM, but you have to take care not to damage the corneal fibrils while doing your stripping. Then it's very important to aspirate all the viscoelastic. Since it's a cohesive viscoelastic that we are using, it comes out very nicely. Then it's a very good idea to restain with trypan blue again to check for any tags and remnants of the DM. And to like conclude it, you should always do a inferior PI. So here we have already removed the epithelium. Now we are marking the descemeter excess area. You can mark it with a trade line. This is the 2.8 mm incision. This is outside this descemeter excess area and two paracentesis side ports. I prefer to put in a little bit of pilocarpine and then I stain the diseased desmus membrane, remove the stain, and now you can begin scoring the margins. You can see the DM is coming off very nicely. It might not always be the case. In some cases, it's very difficult to do a desmetorexis, if especially if the surgery has been quite traumatic. Now we are scoring this DM. Remove it with the capsular access forceps. Now we remove the viscoelastic substance. We restain it again to check for any tags. And you can see few tags here and there. So here you can see the visibility was not that great. So my technique for inferior PI is using two instruments. One is a spatulated instrument. You can use any spatulated instrument. This is like an ISO manipulator and a cystotome. So we go to the periphery and try to bring these two instruments together, create a small PI. You can see a small PI is created there. So why I prefer this technique to other techniques is because this doesn't cause, this is just separating the fibers of the iris, just splitting the fibers, so there is no risk of bleeding here. Some people go for like they use a vitrector, or some people can directly cut the iris using a Vanna scissor, but sometimes it can bleed and it's an unwanted complication which you don't want to happen. So next comes the injection of DMEC roll into the AC. No AC maintenance is required unlike DSEC. Always keep AC underfilled with BSS, and you should be very gentle with injection while injecting the graft. Then before unfolding, you should always check the orientation of the graft. So again, this is the same case with very poor visibility. We're trying to inject it very slowly, because if you inject too fast, sometimes it can go into the angle or even sometimes go behind the pupillary margin. then it becomes very difficult to retrieve the graft in those cases. So this is the case. This blue colored area, this stained area, is actually an iris defect superiorly. There is a PCL inside the eye, but there was a PCR as well. When I went inside to stain the DM, I found that some of the dye went behind the iris and the vitreous was like stained. So here I was very careful not to inject the graft into that area because I didn't want the graft to go into the vitreous. So we go a little bit on the sideways and just open it on the iris plane. So how do we check the orientation of the graft before we start unfolding it? So this is a very important sign given by Motsoris, which is known as Motsoris sign. Before unfolding the graft, we can take any instrument. It can be a spatula, it can be a cannula, and we try to go under the cornea and over the graft. And we see the color of the tip of the instrument. We try to observe the color of the tip of the instrument. So, if your graft is in correct position, that means it is rolled, the rolls are towards the corneal side, you can see the tip becomes blue as soon as you try to go under it. But if it is in the wrong configuration, the tip will not turn blue. But you have to be sure that you have to be between the graft and the underside of the cornea. So graft unfolding and centration. What are the strategies for this part? We should always try to make the AC very shallow. We should never keep the AC filled tightly because if we increase the pressure inside the AC, the graft might sometimes come out of the main wound and even it has been seen to come out of the side ports as well. Then we also use this technique of tapping over the anterior surface of cornea. Then there's similar technique. Then these are multiple fluid injection jets which help us change the orientation of the graft. And then there is this spatula or cannula technique of unfolding the graft, which we'll see subsequently. So this is the graft we are trying to unfold it. So these are the tapping maneuvers. You're actually tapping over the surface of the cornea. This creates fluid waves over surface of the over the graft, and it helps to unfold these margins. So this is the derisimal technique. Here we hold one cannula, put in pressure with one cannula, and tap with another to create these wavelets while making the other part of the graft stable. And it's also very important to maintain centration at all times. You know, observe that the AC is very shallow. We don't make it flat, but we have to make it very shallow so that your iris acts as a third instrument. So these are your one and two instruments, and the underside of iris, it helps to keep the graft in unfolded position. It has to be kept in mind that this part you have to be very patient because sometimes the graft can be very frustrating. It might just unfold and then get folded again. So you have to be very persistent, very slow with your maneuvers, very gentle with your maneuvers. You cannot be rough with your maneuvers, otherwise the graft will get damaged. So we can see with a little bit of effort, the graft is now unfolding. And this is the air temp time. So I was talking about centration previously. It is very important to maintain centration from the beginning because if your graft is on one side and it gets unfolded on one side, it might get stuck into the angle. So you should always avoid the graft going into the angle and you should not push the graft where you want it to go. You actually have to lead it. So here you can see we are using a cannula to unfold the graft. This is the same case where we had an iris defect superiorly. The graft was trying to go into that area. So we just go under the graft margin. You can see this is the Motsoris sign. Here the cannula is turning blue. Gently try to nudge it. And you can use a little bit of fluid waves to open it. And we are going under this flap. You can see the cannula tip turning blue. This is the Motsoris sign. And now we're giving a little burst of fluid to open it. So you can see the S mark there. It's very clear. The S stamp which we have put while harvesting the graft. So here you can see the graft unfolded very nicely. This is the S mark which we can confirm by putting a drop of viscoelastic. I'm sorry. Then this is the point I was stressing upon, getting the centration right. Here we injected the graft, but it has gone into, say, a horizontal position. We want to bring it back into the vertical direction, and we don't want it to go to the angle. So you can make gentle tapping movements near the limbus, shallow the AC a little bit, and then the graft will come into the center. Yeah. The key is keeping the AC shallow. There should be no resistance to the graft by your fluid levels inside the eye. So once your graft is unfolded, next is the graft tamponade with air or SF6. So you can do a complete air fill initially for about 10 minutes, and then you can reduce it to say 80%. It is better to keep supine positioning in post of ward for about an hour. Some surgeons are very experienced. They don't do any supine positioning these days, but it's a very good idea for all beginners to uh, keep the patient mostly in supine positioning in the first say 24 hours. So you can also use SF6. You can use 20% SF6, but again, you don't do a complete air fill with that. You reduce it to say 60 to 70%, and make sure that your PI is patent. Otherwise, the patient might land up in pupillary block. So this is a case where the graft is like graft age was more than 70. So you can see here we didn't encounter much difficulty in unfolding the grafts. See, with just little bit of tapping maneuvers, the graft is trying to get unfolded. This particular one is in real time speed. We have not edited the speed of this video. Using the similar technique to hold the anterior surface with one cannula and using the other to create waves. Yeah, I could see the asthma quite nicely here. So, what is the post-op regimen like? We always put in a bandage contact lens in the OT, keep it there for a week. Then we use, my preference would be to use a steroid antibiotic combination. I use it 5 times a day for around 10 days, and then I switch it to prednisolone acetate 1% from day 10 onwards. And this prednisolone is continued in tapering doses for about a year. And you can also give artificial tear substitutes, SOS. So, what are the complications? Intraoperatively, you can have donor damage during graft preparation, which is quite common in initial stages. Then, again, I would stress to use a pre-strip tissue initially, so you don't have to deal with the additional stress of preparing that graft or losing the graft by having a tear or doing a lot of manipulation. So initially, to begin with, you can order pre-strip tissues when you're comfortable with your surgery part, then you can switch to like harvesting your graft yourself. Then you can have poor visualization of the donor tissue inside the eye. So one take thing already one tip I already mentioned that we can remove the epithelium. Sometimes it might take a lot of time for the graft to get unfolded. You might lose the stain in certain cases. So in those cases, you can again restain it. Just make the AC a little bit shallow, put in a little bit of trypan blue inside the eye, and just gently, very gently wash it out. The donor tissue will get stained again. Then you can have intracameral bleeding, which I talked about, like doing a PI. You can have bleeding from the iris. Sometimes even from the angle, it can bleed. So in those cases, you can give 100% air fill, keep it there for 2 to 3 minutes because it's very important not to have blood and fibrin inside your AC. Then you can also use viscoelastic. You can put viscoelastic material inside the eye to tampen out the bleeding points. Then all of us will at some point of time see that it's we have difficult handling and unfolding of graft. Sometimes the graft simply doesn't want to unfold, but we have to be patient, use different maneuvers, repeated shallowing of AC using the tapping technique. Sometimes the graft may be upside down. So in those cases, again, you have to use these fluid jets till you get it into the correct position. But for both these two complications, you have to be very, very patient because if you lose your patience, then things are going to be very difficult. Then sometimes we have observed that there is graft expulsion from paracentesis or main wound. It's if your AC is over pressurized and you are like manipulating from one of your paras or may from the main wound, you can have graft expulsion very easily. Or sometimes even the graft is lost behind the iris, or it might even go to the vitreous. Then post-operatively, you can have complications, very common complication, graft detachment, which all of us maybe at some point of time we might have encountered. So when actually to intervene, there are some authorities who say like if 1/4 of your limbus, you have a detachment from 1/4, more than 1/4 of your limbus, and the distance between your cornea and the detachment is more than 600 microns, then you should intervene. Then some authorities, Mellis group, they say that if you have 1/3 detachment of your total size of the graft, you should rebubble those cases. And you should not wait for intervention. If there is a detachment, you feel that it needs to be rebubbled, it should be done sooner than later. So one tip I would like to share here is like when we started doing these cases initially, like when we were in the learning phase, we would always tell the patient that you might require two sittings. Like one will be the major surgery where we will be putting air inside the eye to get this graft attached, but sometimes this air is not sufficient, so we might have to put it again in maybe the OPD or the minor OT. So we always counsel the patient in such a way so that he is ready for a rebubbling. Then you might have pupil block due to this air fill, which can be solved by making a PI. You can make a PI, laser PI initially when you're beginning the case, when you're like new to this procedure, you can do a laser PI. Then sometimes you might have primary graft failure. We describe primary graft failure like if the graft, your cornea fails to clear even after 3 months after surgery because of a lot of reasons. It might be because of, say, the graft itself, or it might be because of the intrinsic factors also. Then sometimes you might have endothelial cell loss. Endothelial cell loss will be maybe by the technique by which you are harvesting the graft or the injector which you are using. Uh, like I prefer to use a glass injector because they say it causes least of the cell loss as compared to the plastic injectors. Or these endothelial cell loss might be even because of, say, manipulation inside the anterior chamber. But as you learn more and more cases, this definitely this cell loss rates they come down. Sometimes you might have graft rejection as well in DMEC, but the percentage is very less. It is less than 0.7%, and it is the least among all of these keratoplasties. So it is not actually the obstacles that can stop you, problems that can stop you. Most of all, are not other people. It is just you. It's your mindset. Like if you think you can cross this hurdle, you can do it. And it doesn't take much for any surgeon to switch from PK to DMEC. You just need to practice in wet lab and then do a few cases. Maybe you can observe few cases, or you can take help from one of your colleagues who is already doing these cases. And in my opinion, it is not difficult to make this transition at all. Thank you very much.
Thank you, Dr. Omar. It was a very informative and engaging presentation. Each slide and video clip had many answers with it. And you have almost covered every risk and every challenge that we face in transitioning from PKP to DMEC. I have just one question for you. So, in the context of transitioning, what factors influence patient selection in the patients who have previously undergone penetrating keratoplasty?
If you are a beginner, I would not suggest to take your failed PKs as your first cases for DMEC, because when you're doing DMEC in a failed case, first of all, you have to take a lot of things into consideration. What graft size has been used previously, then how much scarring is there, because when you're doing a descemetorrhexis, the host graft junction scarring is quite variable. So sometimes, because I've done a few cases, sometimes when you go for this descemetorrhexis, there's a lot of fibrosis there. And if you are not gentle with your descemetorrhexis, you can actually open up your graft host junction, which is a huge risk. So for initial case selections, definitely I would not suggest to do to take up a post PK failed graft for DMEC cases. We have to be very careful that in these cases your graft should not overlap your graft host junction. Your graft size has to be lesser than normal. Like it has to be somewhere around 7.5, because most of the PKs will be 7.5. So we cannot go even lesser than that. So preferably, I would not suggest to take up these cases as the initial ones.
Thank you, sir.
There are few cases, Dr. Anu, that one should avoid. For example, as Dr. Omar said, lot of fibrin release bleeding that can also jeopardize your graft opening. So for beginners, always is good to take clean cases of PBK, and you should avoid cases where there is iris damage, iris atrophy is there, or there is a big PI is there. Okay, or there are areas of iris defect, or there are areas of pus where you will do some manipulation and the fibrin will be released, and that will almost make your graft unfolding difficult. So take good cases of pseudopechic bullous keratopathy, okay, and which has an iris which is not damaged more. There are no pars. Pupil is good enough, reacting to pure light, and mostly you will get such cases in cases of Fuchs dystrophy where phaco has been done, and then the cornea decompensation. Complicated pseudophakia are always a challenge for beginners. Uh, and also like ACL, you should not take ACL cases or AFK cases. All these cases should be avoided. Dr. Omar, am I right?
Yeah, yeah, definitely. Say if you take these ACIL cases, there are chances that your graft might rub against the lens. Iris is quite friendly to these endothelial cells, but if you have these ACILs, they are quite damaging to your graft. So even in experienced hands, you might have a lot of endothelial cell loss. Then again, your pupil architecture, it's very important. Like if you have a damaged pupil, it's better to do a pupilloplasty in one sitting and then do a DMEK in the next sitting. It's very important to avoid these cases because you don't want your graft to like go behind the iris or into the vitreous cavity. It is better to keep these complications in mind and not have them because initial cases, if you have all these complications, your confidence is shattered, then you will never be able to transition.
Dr. Omar, would you advise our audience to go from PKP to DMEK, or should they first learn DSEC and then move on to DMEK?
Sir, in my opinion, I will say that there are no similarities between DMEC and DSEC. The only part that you learn while doing a DSEC is maybe your desmetorexis, your preparation of the host part. But apart from that, the graft handling and everything, it's a totally different field. DSEC is a totally different, has a different feel to it, but DMEC is absolutely different. People can transition, in my opinion, people can transition from PK to DMEC. They should have proper guidance. They should watch videos. They should maybe observe a few surgeons how to do it. But in my opinion, it is not important to go to DSEC first and then do a DMEC. I'm sorry, you are not
Sorry,
audible.
sorry. So what I'm saying is, if you are a experienced DSEC surgeon, then learn shipping to DMEC becomes easy. But it's
Yes.
not that it's a mandatory. You can
No,
always,
it's
if
not
you want
mandatory.
to shift from PKP to DMEC, you can still do that.
You can say it is same like transition from ECC to phacoemulsification. It's not necessary that you have to go to SICS to learn
This is
phaco first.
Yes,
So
most
you
of our
can
RP center resident does that. From ECC to jump onto PECO only without any knowledge about SIC.
you can switch to DMAC because I will cite a personal experience because I was not very well versed with DSEC. Like I had experience, I had done cases, but I would say it didn't help me that much. Only the desmetorexis part that we had only learned in fellowship only. So I don't think it's a must to learn DSEC first. There is no hard and fast rule about it. You
Also,
can directly switch to DMAC.
also another important point for our audience today is all those instruments. For DMEC, instruments becomes very what to say critical for the success of the
I would stress
procedure. Yeah.
especially on the injectors.
Yes. So injected everything. In fact, while if you want to prepare your graft on your own, then also use those instruments that are meant for DMEC. Don't try to make adjustment, use cataract instrument. You could do that later on once you are confident and you have done 50 plus DMEC, then you can use those instrument. For those beginners who wants to shift from PKP or DSEC to DMEC, please buy some specialized instrument. And
Yes, these
I must
mm,
say, Joja is quite good in that. Although I
yes.
don't have any financial interest in Joja Surgicals, but their instruments were quite handy for DMEC. In
Yes,
fact,
and they
all
are
corneal
actually
procedure.
coming up with the innovations. They're actually coming
Yes,
up with the innovations. Like I was talking about this S stamp and P stamp. Now they have come up with a disposable S stamp. You can actually put in a
yes.
S stamp. It's just like it has a handle, a plastic handle like a Christian blade. You can just later throw it away. But these very small instruments, they are very important, like put in a S mark. If you don't an S mark, you don't know what you're doing. You don't know whether even your graft is in the correct position. So these very small instruments, they make huge differences in your surgery.
And their partial trephine also quite handy, that 100
Yeah.
micron trephine,
Yes.
because
Yes.
if you go deeper, then you will struggle in peeling the DM. In fact, this is what we struggled when we were learning in the initial stages. We had that manual trephine. So
Yeah.
even if you try, no matter how much you try to go partial, there will be some area where you go deep. Then it
You go
becomes
deeper,
very,
yes.
yeah, when it becomes very difficult to lift the flap from that side. But with the 100 micron trephine, it's very easy. Okay, there is one questions from one of my resident. Is it a good idea to do DMAC triple, or just do a fake one, do a subsequent DMAC?
There are again depends upon the experience of the surgeon. But if you are a beginner, definitely I would suggest to go for a staged surgery, because like when you do a phaco and put in the IL inside the bag, at that time the IL is not that stable. Either you have to make a very small rhexis so that the capsular overlap is quite good, but still the IOL is not as stable as you would do in a stage surgery. So in my opinion, if you are a novice surgeon, if you're a beginner, it's always a good idea to do a stage surgery. Do a phaco first, and after some time you can do a DMAC. If you have like if your cornea is bad, the view is not good, say there is little bit of epithelial edema, you can always remove the epithelium, do the phaco, and afterwards you can do a DMAC.
One more question is, would you like to prefer air or gas for air tamponade for beginners in DMAC?
You can easily put SF6. That's quite a good idea. Although I have never used, but now looking back at my cases, I think it might have been a good idea to use gas in some of my cases
In the
where
beginning,
I
it's
had
good,
to,
but yeah, if you have
yeah,
done a
where I
PI,
had to
then there is no
debubble.
problem
Yes.
with going for a gas. Dr. Anu, I think, do you have any more thing to discuss?
No, sir.
It's already 8:30. Thank you, Dr. Umar. It was a
Yeah.
wonderful lecture,
Thank
and
you. Thank you very much.
it will help our beginners, because this Super Tuesday cornea surgery learning, we are targeting the beginners only. We are not targeting experienced surgeons. So we are targeting those ophthalmologists who are just doing PK and want to go for DMAC, or they are just learning to do PKP. So all these courses, this 12 webinar series in association with, of course, Jodha Surgical, we have planned in such a way that these beginners, they will get some advantage after going through our webinar series, and we are going to keep it in our YouTube channel as an archive. So anybody who whenever wants, he can always come back and just check those videos, so that to recall what should be done or what should not be done when you are learning some new corneal surgery. Thank you so much. And Dr. Anu, please conclude.
I would like to thank everyone attending this webinar, with a special thanks to Dr. Omar for this
So Dr.
engagement.
Omar, just a reminder, our audience link is different. Don't think that there are only 4 people in this webinar.
Yeah, yeah, I
So
know.
our audience link is different. Huh?
I know, sir.
A special thanks to Dr. Omar for this engaging presentation.
You're welcome.
Have a great evening. We look forward for our next event of DOS Super Tuesdays. Thank you, everyone.
Sure, sure. Thank you.